I'm so pleased to welcome you all to the Common Good Breakfast Series. I hope you're in the right room. On behalf of my team at Nuger Communications Group, I'm Joanne Henry, Senior Vice President, and today's topic, the future of medicine, is one that's been on our radar for a long time because we think it really has impact for all of us, for everyone in this room. And we are so fortunate to have individuals at the forefront of some of the changes in healthcare and medicine with us today, and we're very grateful for their spending their time with us today, including our moderator, Lee Schaefer. So thank you, speakers. If you are new this morning to Nuger Communications Group, I just want to tell you just a little bit about us. We are a marketing, communications, and public relations firm, and we provide a broad range of communication services to our clients, from strategy to websites to branding, media relations, social media, advocacy, research, and more. And if our president, Dave Nuger, is here at the back, you can wave. Dave, he's hiding. Always hiding, but anyway, if you are sitting next to my colleagues, please say hello to them, and if you'd like to hear more about this series and be invited and be sure that you're included on invitations to future events, please let any one of us know, and we'll be sure to add your name. So Nuger Communications Group works with for-profit clients, with nonprofit organizations, and higher education, and you'll see that all of those important sectors are here in this room today. If you're new to the Common Good series, we choose topics of broad interest and bring in speakers who are doing some remarkable things for the common good. And when you attend, you're also doing something important for the common good by supporting a very worthy nonprofit. And today, we're very happy to give back to the community and to, with all of you, help donate the proceeds of this event to Gillette Children's Specialty Healthcare, and you'll hear more about them from Dennis Jolly very soon. But finally, I do want to also thank some sponsors who helped make this event possible. The team from First National Bank of Northfield is here with guests, so thank you for coming up. And they do commercial lending services and other banking services actually throughout the Twin Cities, in Northfield, and throughout our region. So we also appreciate the support of Engage Printing, our partners, and Flight Creative Media, the excellent team who's doing video support work for us today. So thank you, you guys. So as I've told you, this event benefits Gillette Children's Specialty Healthcare. Founded in 1987, Gillette Children's Specialty Healthcare became the nation's first hospital for children who have disabilities, and today this vital organization provides special health care for people who have short-term or long-term disabilities that began during childhood. And before we begin the program on the future of medicine, we've asked Dennis Jolly, Vice President of Institutional Advancement, to tell us just a little bit more about Gillette. Thanks.
Good morning. Thank you for having us. I want to thank Nuger Communications for sponsoring the Common Good Breakfast. What you do is really great. You have in front of you a book, and if you're curious why we gave a bunch of adults a children's book, one, who doesn't like a good picture book? Two, we figure that most of you know or have heard of children before. And so why would we do a book? Well, Gillette was founded in 1897, as Joanne said, as the nation's first hospital to care for children with disabilities. And over the last 118 years, we've grown and evolved into an organization that really leads the nation and the world in the care of children with complex, rare, and traumatic conditions. What do we mean by that? Complex conditions like cerebral palsy, like intractable epilepsy, children who have spina bifida, or other complex neurological, neuromuscular, or orthopedic conditions, traumatic brain injury, spinal cord injury. Rare conditions like some of our panelists today are working on treatments and hopefully cures for, like Rhett's disease or brittle bone disease. These kind of conditions that affect children and then affect them throughout their whole lives, and they affect the whole family. So in honor of National Bullying Awareness Month, which it is if you didn't know, we brought you this book, which we encourage you to share. We were able to work with a local author, but nationally known children's author and illustrator Nancy Carlson to produce this book. This book is Stories of Gillette Kids, and it's about how by reaching out and not being afraid to ask each other questions, we can grow to better understand each other. It's part of our effort to advocate for our children outside of the hospital, as well as provide outstanding care for them in the hospital. So thank you for having us. If you have any questions, I'm here. My colleagues Patty Dunn, Catherine Wardrop are also here, and we appreciate you having us. Thank you.
Thank you so much, Dennis, and thanks for the outstanding and so needed work that you do at Gillette Children's Specialty Healthcare. And welcome to Catherine and Kelly as well. So today's topic, again, I think something of impact for all of us, and delighted to have these speakers. I'd like to introduce them to you just briefly, and then they'll have some opening remarks, and then our moderator, Lee Schaefer, will ask formal questions, but we will then go into a Q&A session at the end. So keep track of your questions. We'd love to have some audience engagement at the end. So Robin Young, seated one over, has been on the forefront of changes in healthcare for many years. Delighted he could make the trip here from Philadelphia. And Robin has been is a former Wall Street analyst. He's been covering medical technology, among other sectors, for many years. He's chaired the New York Stem Cell Summit for years, and today he is CEO of RRY Publications, and they're publisher of the very widely followed Orthopedics This Week. He also has a consulting business providing research, data, and counsel to orthopedic firms. He's a frequent national speaker, and he's also founder of the biologics firm on the forefront of change in that arena, Leventa Bioscience. He's author of 5 books and more than 1,000 research papers, and he celebrated his birthday yesterday with his mom in St. Paul, who's also a wonderful writer and published author. Eric Timko is the president and CEO of Bluebell Technologies, a company focused on developing clinically relevant applications in computer-assisted technology and robotic orthopedic surgery. He's got experience in medical technologies at both the startup and the later stages of development, from previously serving as president and CEO of Neurovasc, president of Carl Zeiss Surgical, and vice president of Siemens Medical Systems. And finally, Brian Van Ness is a professor in the Department of Genetics, Cell Biology, and Development at the University of Minnesota Medical School. Dr. Van Ness is also founder and CEO of Target Genomics, LLC, that focuses on guiding healthcare providers on the use of genomics. He's been an active member of the NIH committee, has recently co-created a genetics and law course at the University of Minnesota Law School, and he's especially interested and focused on the field of pharmacogenomics, something that I shorten to personalized medicine, but I'm not a doctor. And finally, our moderator, Lee Schaefer. Lee Schaefer has been a business columnist for the Star Tribune since 2012. Many of you, I'm sure, read his column regularly. While Lee covers a wide range of topics, from highly complex financial mergers and acquisitions to the problems with Tesla, tax law, and certainly medical technology, he brings a human scale to every business topic he encounters. He's written extensively about healthcare and medical companies in Minnesota, a topic of great interest to the thousands who work in this sector and either or are affected by it. And before joining the Star Tribune, Lee spent 15 years as a corporate officer, consultant, and investment banker in the Twin Cities. He's been a columnist for Twin Cities Business Magazine, was senior editor for Corporate Report Minnesota, and he has a degree in economics from Macalester and his master's in journalism from Northwestern University's Medill School of Journalism. Finally, I've personally known Lee since we spent some time together with a savings and loan client of mine in St. Cloud, when Lee then wrote the story titled, "Alive and Well Among the Living Dead." Thanks for that headline, Lee. We remain friends. Lee and his wife Tanya have college daughters on both coasts and in Grinnell, Iowa, and he joins us today from St. Paul. So, Lee, please kick it off.
Well, good morning, everybody. I think that we'll have each of our speakers give a little intro. I just wanted to share a couple of things. I do write a general interest column for the newspaper. People want to talk with me at great depth about healthcare after I've written a healthcare piece. And I said, you don't seem to understand. Today, what I really care about is the hay harvest. I have to talk to you later. So I do have a wide variety of things that I have done some research on. I consider myself a pretty knowledgeable amateur when it comes to healthcare. But I'll share a couple of, I'm very interested in this panel. It's almost too big of a question, of course, but one of the things that I think it's really important to realize is how it's been changing for generations. Everyone talks about the rate of change has never been greater. That may or may not be true. I wasn't around in 1950. Maybe physicians and others really struggled with the rate of change then. But it's obvious what some of the trends are that are going to drive healthcare. About in July and August, for instance, around our place, a lot of pedometers show up. And you can see them primarily on the boomers, but they sort of show up all over the newsroom. And they're wearing pedometers, and they weren't there in June, and they'll be gone in October. So what's happened is our health insurance gives us a break if we do a few things to take charge of our own health. It's not much of a break, but journalists are really cheap, and it's enough to change behavior. And so the easiest thing to sign up for is to wear a pedometer and track your steps. And so they show up all over the newsroom, and they're gone again in October because it's a September 30 deadline. Now, how much permanent behavior change was driven by that? I don't know. It could be approximately zero, or it could be, in some cases, a change that made a lasting difference in a person's life. But that's an example of what I think we're seeing, where the people paying the bills for healthcare are expecting people to take more charge of what they're doing. Diet, lifestyle just being part of it. Another thing that I think it's important to talk about, and I really want you to keep this in the room, because I don't want protesters outside my office, but I don't hate the Affordable Care Act. I mean, I kind of don't understand why, spittle flies from people's mouth and they turn red and their veins bulge when they talk about Obamacare and the Affordable Care Act. There's some really interesting things about that. And there's one fundamental thing about it. It's mostly about health insurance. It's not healthcare reform, it's really health insurance reform, and we're now years into its implementation. But there's one really important thing about that, and it's buried in there. And when they say it's a huge law, it's true. I don't know how many pages it is, but the PDF, when I downloaded it, the email stopped for about 5 minutes in the whole newsroom. But the thing about it is it had, I call it accountable care organizations. It was a way to think about paying for health care differently. We're no longer going to pay and reimburse organizations for doing procedures. We're going to pay for keeping people healthy. Now, this had been kicked around by the wonky types for a long time, but this is where this is sort of the start of this policy. And I think this is really interesting, because if you look at the incentives for healthcare and healthcare delivery, it's been about paying for procedures for a long time. Having somebody be unhealthy makes them a better client long-term than healthy, provided you can keep them alive to do more procedures on them. I mean, that's kind of a weird way to think about healthcare delivery. But those are the incentives. Doctors, if you say this to physicians, by the way, they just object to the whole concept. But I think those incentives were clear. So if we pay people, providers, to keep people healthy, how does that change the way they deliver service? How does that change the way they interact with the patient, the customer, the consumer? It's very interesting. That's one aspect of the Affordable Care Act. So now I'll shut up. I'm an amateur. We have experts up here. I don't know which one of us will decide we're going to go first. Should we start down there? Thank you very much.
I can just advance from here, can I? Okay, if I just hit next slide. Okay, thank you very much for the invitation. although having said, telling you about the future of medicine in 5 minutes might be a bit of a challenge. So I am going to focus, and it's a personal focus of mine in a research area, but one that I'm very passionate about, and that if you look around the room, look around the room, everybody looks different. Unless you're sitting next to your twin, everybody looks different. Why? Genetics. And you look different on the outside, you're a lot different on the inside from the person next to you as well. So it should come as no surprise to you that your risk for developing a disease, once you have a disease and how it progresses, how you respond to medications is going to be different than the person sitting next to you. And that really is the key element of this new age of medicine, which is becoming disruptive in the medical field, and that is the use of personalized precision medicine that makes use of your genetics. So let's consider the problem. First of all, if you prescribe a drug, it's been found that about 20% of every drug that's prescribed doesn't do what it's supposed to do in the patients that it's prescribed to. It often results in adverse events, toxic events. In fact, it's the 4th leading cause of death in this country, contributing to about $150 billion healthcare cost is toxic effects of drugs, because not everybody is responding appropriately to the drug as they might be expected. Now, in a recent survey, about 98% of physicians said, I should be using more personalized approaches, more genetic information in treating my patients. But the field has changed so rapidly in the last 3 to 5 years, only about 10% of physicians are even prepared to use that kind of information. So there is a huge gap that needs to be filled. So there are a lot of factors that influence drug response. Compliance, you have the patient, you're supposed to take 3 pills a day. They forget to take it for 2 days, so they take 9 of them on Wednesday. That's a problem, okay? But there are other components, but the one I want to focus on is genetics. And that is, we know that the genetic information in every individual has the potential to identify and predict how they're going to respond to medications. Some will be responding to a drug, some won't respond to a drug, and some people will have toxic side effects. And it's the genetics that is going to provide some of the predictive power to identify each of those kind of categories so that medicine is going to be more effectively applied. So the impact in the clinic is that we now have the capability with genetic information to provide patient-specific therapies, not group, not everybody gets the same drug at the same dose, patient-specific, improve the effectiveness, make sure it's effective without being toxic, identify risk in genetic typing for people that might be at risk for developing disease, that influences the prevention, identify the toxicities that might be apparent after a genetic test and avoid them, even salvaging drugs in development. We know that there have been pain medications that have been pulled off the market because less than 1% of the population might have a heart attack risk for a pain medication, but 99% of the public that takes that medication benefits tremendously. If we can identify the genetic predictors that identify the people at risk, the 99% will gain the benefit again. And then as we understand genetics, we're going to understand biology better, and we're going to understand new approaches and new therapeutic targets. So physicians will have now, I think, the appropriate computer software in their offices that are going to provide the important kinds of decision support. So I think the future of medicine is going to include genetic information about each patient. Right now, the FDA has recommendations on genetic typing that influences choice or dose of drugs on well over 80 different drugs. It's probably up to about 120 now, and their use is currently high. Genetic predictors of response in drugs is being used in clinics in cardiovascular disease, cancer, psychiatry, pain, among a number of other different symptoms. And so companion genetic diagnostics is rapidly advancing, and I think that's going to be an important consideration in the future of medicine. So the take-home message in my 5 minutes is that genetics in medicine, think of the 4 Ps. It's personalized, it's predictive, it's preventative, and most importantly, it's participatory, because you as an individual have the right to ask the question. As a doctor is diagnosing you and providing a drug to treat you, the question you have an appropriate cause to ask, is this the right drug at the right dose for me? And that's going to be the future of medicine, is this personalized, individualized therapeutic approaches. Thank you.
Thank you very much. Let's see here. I'm Robin Young, and it's a pleasure to be here today. I'm actually going to start with to remind us all and maybe inform us all about the complexity of the subject matter. Oops, wrong direction. So this is a map of the Human Disease Network, and it's probably the most comprehensive map anyone's ever put together. And yet it is, almost by definition, inadequate. Now, each one of those points of this, call it a universe, this galaxy of disease, represents underneath it a whole series of treatment modalities and strategies for treating and this does not, by the way, include trauma, wars, auto accidents, and so forth. So to kick us off with maybe a little bit of humor, you know, the human impulse to try to put labels and define things in order so that once we've defined it, we can, treat it. So on October 1st, 2015, just a few weeks back, the medical establishment adopted the new ICD10 codes, which try to put, define all that medicine or all that disease network. And at my publication, we went through it and picked out about a dozen of the more crazy codes. And I thought I'd share 4 of them with you this morning. And again, my basic underlying message, aside from the humor, is how complex this problem we are all attacking is. And that will lead to, I think, our next speaker. So they came up with 46,000 ICD-10 codes to describe all these things. So I picked out 4 here. There is a code if you have a burn, if you suffer from a burn from water skiing, if the water skis are on fire. I don't know if that ever happened to any of you guys. But I did find a photo from the Wisconsin Dells, and they do smoke coming off water, so it could happen. Now, this next one is there is a code for sibling rivalry if someone is injured due to sibling rivalry, and I found a photo of a little kid who painted his sister. And our guess is that this code was for the moms, not the kids. So when the mom comes into the emergency room, the nurse says, "Why are you here?" It said, "Sibling rivalry." And she says, "No problem, we have a code for that," and a spa. There is a code for prolonged stay in a weightless environment, X52. Now, always the muscle atrophy. You hear about weightless, always the muscle atrophy, never the hair. You know, weightless hair is a significant issue, and we have a code to deal with epically unruly hair, and there you go. Finally, there is a code for type A behavior, Z73.1, President Trump, what Z73.1 was made for. Now, there's about a dozen other ones, and they're just dead. So if you want to hear about the rest of them, we have it in our publication. That's a subtle pitch, you guys get it. Okay. So I have been actually in the field of helping direct capital towards medical innovation for about 32 years. I didn't know it was that long till last night, and I was calculating, and I started my career a few blocks from here at the original Craig Hallam, and I remember the day I started my job as a junior analyst, they had recently underwritten this little startup company called St. Jude Medical, and they came out at $3 a share, I remember, which I think today, if you adjust for splits, is probably a nickel a share. But for the remaining period of my career at Craig Hallam and Piper and then later Stevens, I was really responsible for trying to figure out which one of these many implants, whatever they might be, whether it's a balloon angioplasty or drug-coated stents or whatever the heck it was. In fact, I remember now, I was working for a firm called Stevens, which really had a lot of doubt about medical technology. They kind of suspicious of this stuff, And so I remember I was pitching them on why they should invest in stents. And I pulled out a Bic pen, and I undid the Bic pen. I pulled out that little spring, And I asked the guys, I said, "Guys, how much do you think this cost?" "I don't know, half a penny." "Right. So a stent is like this, and it sells for $2,000. I'm in. So, I tell you, that was the best pitch I ever made, and it worked. Now, after all those years of that, about the kind of the, I met a fella working for Smith and Nephew. The firm was named for Smith and his nephew, and he was telling me about growing body parts. And I spent a full year just going to all the labs who were growing body parts. I'm talking about the Facanis at Harvard, MIT, UCSD, University of California, San Diego, and I became an expert in this. I've written, as Joanne said, about 4 books on the subject, and we never actually put money behind that activity, even as really sexy as it was. We actually decided to put our money behind what's called allograft, because I really felt when I did that I was trying to define the next pillar of medicine, which is biologics, which is related to what our previous speaker is doing. And biologics is actually older than most people realize. This is a painting of Adam and Eve, and Adam receiving a bone from, a rib from Eve. I won't read Genesis 2:21 to you guys, but you know the story. And we're still donating bone to each other even today. Now, that fundamental, simple act of donation and what that means, that has now blossomed, and that's the subject of what I've been doing research and writing on, and something called stem cells. So I came to the conclusion about 10 years ago that stem cells were being truly misunderstood. It was moving quickly into the marketplace, and I started the Stem Cell Summit in New York, and later on gave the keynote address on stem cells at the Vatican. And the stem cells, there's about 40 companies today providing stem cell products to patients, including Johnson & Johnson. In fact, I just gave out a series of awards last week for new technology. One of them went to J&J for their stem cell product. The issue with stem cells, however, if you move aside their function as a bone growth medium, is they only work about 50% of the time when they're applied. And no one really knows why they work, how they work, and no one has really defined it. And after all of this time, the FDA has only approved one stem cell product, and there is no stem cell product on the horizon coming out of that gauntlet at the FDA. So I stopped the Stem Cell Summit about a year ago and began focusing on some of the other more proteomic type technologies for healthcare. And frankly, the genetics side, this is where I see things going. So in the coming years, the critical needs that are going to be solved by new technologies are not what I grew up in, which was an implant-based system. It's really to solve some truly long overdue problems in healthcare. And I will start with what I think is the #1 problem, which is variability in surgeons, variability in outcomes, and variability in cost. The system, broadly defined, is fed up with a surgeon in, I'll pick Florida, doing a knee replacement for $100,000 and getting lousy outcomes, and a surgeon in Green Bay, Wisconsin, doing the same procedure, getting terrific outcomes for $15,000. It's ridiculous. We are moving, we have to move, and we are going to move to a situation of greater homogeneity, predictability, outcomes that you can rely on. Now that means physicians are going to have less choice. Physicians are going to be mandated in some way or another. And I think, not a panacea, but an important development, and one that I think is coming. There are 2 main technologies that are driving it. Our next speaker is going to tell you about one of the most important, and the other one is data mining. And I think data mining, which I think if you apply data mining to medicine, what you're really doing is you're data mining the fingerprints of God. So with that, it is my great pleasure to introduce a guy who I think is changing medicine, Eric Timko.
So first of all, I didn't know I had such a good setup guy. I appreciate that, Robin. Second of all, my takeaway so far is I cannot wait to go home and tell my wife the caliber of people I sat on a panel with, so hopefully she then puts me in that same caliber and thinks I'm as smart as they are. So anyways, we are Blue Belt Technologies. We are actually a company spun out of Carnegie Mellon, the Robotics Institute in Carnegie Mellon. I've been CEO for about 5 years now, 4.5 years. I moved the headquarters to Plymouth, Minnesota, where we live, actually in Orono. But we keep our research and development facilities in Pittsburgh, and now we have offices in several countries focused on orthopedic robotics. And so, again, when we talk about the future of medicine, we'll go to the next slide. You know, we actually believe that the future, at least in our space, is getting close to being here. And as Robin said, we are focused on fundamentals, which is consistency and accuracy in the patient outcomes. And so I'll show you how we do it and why we do it. But if you look at the industry itself, it's hips and knees, right? So it's basic, it's carpentry work. And if you look at how it's done, and I'll explain a little about that later, but it's really controlled by 4 major implant companies, and you all know the names. It's Johnson & Johnson, it's Zimmer, it's Stryker, it's Smith & Nephew. And they all care about pushing metal implants, whether it's your hips, whether it's your knees. That's what they want to do, and that's where the majority of their billions and billions of dollars of revenue come from. With that being said, the technique to put these in is archaic. It's been the same for years and years and years, and it's using saws, it's using jigs, it's using drills, and it's using basically the eye to line up a lot of the things that have to occur for the implant to go in correctly. We at Blue Belt, and there's several other companies also, are vying for introducing technology that sticks, and sticks in the sense that physicians adapt to this, that make hard procedures easier, make these difficult to perform procedures more consistent and more accurate. And the guy that only does 5 a year will do this, get the same results or outcomes as the guy that does 105 a year. And so we bring that into play. The market itself is huge. There's about 750,000 knee replacements done a year in the US. The difficulty is that 20% of those patients are not happy after their procedure. And so what we're trying to do is figure out why, focused heavily on clinical results, clinical outcomes, and moving us to the forefront. So again, there's a couple ways to do it. We are in the robotic-assisted category, but there's really 2 focuses. One is implant design. So you can make them smaller, you can bring new materials in, you can make them gender-specific, you make pink ones, you make blue ones, whatever the case may be, whatever it takes to sell more implants. And if you tie a neat marketing tool to it, it could work, because of Google and all the things that a patient that needs a knee replacement says, hey, I need my knee replaced, what do I do? And the plethora of all these options will come up. We believe the technique side, so if you look at the implantation technique on the other side, is where this is all driven. And so there's a lot of different ways to do it, and if you look at navigation, that's been around for quite some time. What navigation does is it takes you to the specific anatomical zones that you're trying to reach, or the physician's trying to reach, and that's great, right? Because you want to make sure you get to the spot, especially if you're removing a brain tumor or fixing an aneurysm in the head. You can't screw up, right? Because that's a life and death. If it's a knee, you know, maybe you have a limp coming out, but a brain aneurysm, that could be death. But what happens with navigation, it gets you to the right spot. But then it comes to the physician and the physician's hands to take over from there with no backstop. And so what we do differently is we bring robotics into it. So we will get you there through our navigation, and then once we get you there, which I'll show you in a few slides, the system itself allows the physician to paint within the lines and not color outside those lines. And if you color outside the lines, you're removing good bone and good anatomy. So again, if you look at the evolution of robotics, what I always say is people think of robotics as the commercial for Toyota, right? Toyota has the big arm that picks the piece of metal up, it's the hood of the car, next thing you know, it builds the car in about 6 minutes. That's robotics, that's not us, right? What we do is called semi-active robotics, and we allow the physician to engage the tool. So the physician has to do his job, we have to do ours. So if the physician starts to make a mistake, as I said, we protect it. The biggest difference between us and some other technologies out there today, we believe in doing it in a small footprint in an economically friendly environment. And so the physician uses a freehand sculpting tool, as we call it, to shape the bone in order to fit the implant, versus a big behemoth of a robot sitting next to this physician that's really pushing the surgeon to do the procedure that way. So we're in partial knee replacements out of the gate. You can see there's 80,000 of them done a year. You can look at the pictures and say, what is wrong with the one on the right? And again, that is due to the accuracy of the implant, right? So you can use your standard techniques and your tools, and if it goes bad, it goes really bad. If you look at the next slide, these are a lot of really bads. And so if you think about a person who has bad knee pain going in, look at the knee pain coming out. Right? So now you're going to have just as many issues coming out of the surgery as you did going in. So again, what do you look for as a robotics company, and what are we trying to do? We want superior and consistent results. We want measurable information. We track every patient, every procedure to make sure not only are we getting good clinical results, but we're efficient. We cut down on all the risk factors that go into the procedure, and that patient has multiple reasons that they should come out and do better. We're in a significant economical environment. We talk about Obamacare and all the things going on with the Affordable Care Act. We have to be economically considerate of what we're trying to accomplish. So what we do is we sell a system that equals our competitors. We sell it for a third of the price. Theirs is $1 million, ours is about $350,000. We get the same results, but we do it in an economically friendly way so that we can do it in a hospital, we can do it in a surgery center, we can do it in a community hospital or a teaching institution. So all of that comes together to allow us to move this in the right direction. And here it is. So it's a freehand handheld tool. And so as you can see in the video, when the surgeon engages to the plan that they created to shape the bone to fit the implant, the burr will extend or retract based on the depth or the width of where that cut needs to be. And so you can see in the zoom in how the burr is moving in and out. And that's it. It's very simple. It's very elegant. But our surgeons know the outcome of that procedure before they ever put the tool on the bone. So you know your fit, you know your outcome, you know your gait. That's going to come from your ligament alignment before the procedure is ever even started. And again, we have several benefits as I talked about, and my 5 minutes are up. And again, one more key point is we all know that we're in a regulated environment. There is a new Comprehensive Care for Joint Replacement Act that's coming out. We fit nicely into that because again, if you look at the last couple points, there are certain things happening that will push for more consistency, more accuracy, but most importantly, more accountability, reduce infection rates, focus on outcomes, and those that do well with those things will get a higher reimbursement. And so we think we bring that into play. Thank you.
So now we'll transition into a panel discussion. So panel, I'll ask a few questions, and I might address them to a person, but if you have something to add, just feel free to jump in. And I think, Brian, I'm most interested in, I would call it the affordability of personalized medicine, and where are we in the process? Is this a 2027 kind of broad adoption or much closer than that?
No, I think it's a lot closer than that. I think there are some very interesting studies coming out demonstrating the cost effectiveness of genetic testing. Let me give you one example that has a huge impact. Plavix, used for cardiovascular disease, a very effective drug. However, it's a prodrug that needs to be activated. It's activated by a genetic event, the protein that a gene produces, and about 15% of the population has a genetic variant that doesn't activate Plavix. Now, what's the economics of that? Plavix is prescribed at a rate of about $6.5 billion a year. If 15% of the patients do not get benefit from it and are increasingly hospitalized, just that one drug alone has about a $975 million wasted application by virtue of the fact that 15% of the people shouldn't be getting it. There are alternative drugs. So I think that's just one example, and there are many of these now hitting our understanding and are being applied. The other area that I think is really having an impact is cancer. People's cancers are different. There are genetic variations that dictate what drugs are the best drugs in a number of different cancers. That market is here today.
Are these kind of tests commonly reimbursed under current policy? Can you get paid for them?
The answer to that is, of all the possibilities, all of the above. Some of the tests are not reimbursed. Some of the oncology tests for cancer genetics are reimbursed. This is all a very quickly moving process now that the insurance companies and the payers are almost having to evaluate every 6 months to determine, is the next genetic test going to be reimbursed? So it's a rapidly moving target right now.
Okay. Well, I think it's a similar question for Robin. I know that you did a lot of work on stem cells, and I guess I'm a little bit puzzled that there's not broader adoption of this stuff. Is economics part of the problem, or could we afford these things? In other words, could we afford these treatments?
Sure. Well, I think the big issue is the lack of predictability of these therapies. They are available. Last year, there's about $300 million worth of these products sold. but the outcomes are just not as predictable as they need to be to become a real standard of care. The doctors I talk to that have tried them, they routinely tell me about half the patients benefit, half the patients don't. They don't know why some do, some don't. And until a therapy is routinely successful, these kinds of therapies are only going to be used for patients for whom every other option is run out prior to surgery. So that's the biggest issue with stem cells, is they're just not, they don't work routinely and predictably so far.
So if we do some of the things that Brian has talked about, should we be
Yeah.
able to narrow that down?
No, honestly, I think stem cells are a dead end in many respects. I think the areas that Brian is going into are much more precise, much more measurable, much more likely to have better outcomes. Stem cells it's an extraordinarily complex mix of proteins and activities, and they respond to their environments. They're almost independent actors in their own way, and they are extraordinarily variable based on the patient. It is, I think, fundamentally a mistake to think that stem cells as a single sort of therapeutic entity could routinely accomplish some outcome outside of something very simple like growing bone. Outside of that, it won't do soft tissue necessarily, like cartilage. So no, I really think the approach that Brian is going is fundamentally more accurate and more likely to produce predictable outcomes.
If I could comment, I would take one exception to the fact that as we understand the biology of stem cells better, as the research continues, as the genetics and understanding of that genetics improves, the predictability of stem cells will get better. So I'm not sure if it's a dead end. I said today it may not be very effective, but as the research continues and we understand that variability better, there may be increasing applications.
Oh, I don't agree, but that's okay.
Okay.
One of the things I'm curious about as a consumer, why shouldn't I just walk around with my full genetic code on my iPhone to present to the physician when I get to the ER? Can that be cost
You
effective?
might lose your phone.
I might lose my phone. I've lost it before, but is that where this is going?
You know, that's a complicated question with lots of answers, but the answer is, of course you should. But part of the problem is that we've got a bit of a data analysis problem, and that is your entire genome tells you something about yourself, but we understand only a fraction of it. So there's a lot of information in there that we don't understand. There are a lot of variants we don't understand, but there are variants we do understand, and that's getting better. So I think there will come a day when, in fact, everybody's genome will be defined and physicians will have access to certain parts of that that are understood. But again, it's an evolving process, and there's an enormous amount of data that's being generated from that that we really just don't understand at this point.
Thank you. Again, I think economic incentives do drive a lot of decisions in this profession, in this industry. So Eric, I have a question for you. Is this an outcomes-driven sale, or is it an economic-driven sale? And what do people care about as you're out talking about your story?
Yeah, I think it's a combination of both. I think that the outcomes are clearly the most important to the physicians and the caregivers. But if the outcomes come at a cost that is unattainable for institutions, then it makes no sense to blow the budget on a technology that just doesn't fit into the entire environment. So we have focused heavily on making sure the economic benefits match the clinical benefits. As important, for example, is a lot of the knee replacements are moving from the hospital, where these procedures are very expensive, into the surgery center, where the complexity is reduced by using technology such as ours. You have a staff that's consistent, and you have physicians now that can get through several patients a day because they don't have to go through all the staging you go through in a hospital, perform more procedures, and the reimbursement is much higher.
Go ahead.
The other element here is there's a real consolidation of payers going on. We are probably getting to a stage of maybe 3 or 4 insurance companies maximum, and they're huge, with Medicare being the largest payer. And the basic trend coming out of this consolidation of insurers is to bundle what they'll pay for a specific event. So we're talking knee, we could be talking a disease, but the payers establish a flat rate. So it's, I'll say, 20 grand for a knee replacement, and you have to guarantee the outcome. So if your knee replacement's not working, You're gonna eat the cost of the rehab or whatever you got to do afterwards. This is a fundamental shift, as you as patients will likely experience if you aren't already. When you're going, and by the way, Twin Cities Orthopedics here pioneered some of this stuff. They're that flat rate charge for everything. And this is a big change, and it's just going to flow through, I think, how care is given. And these two gentlemen are actually describing techniques that can get us there through either the robotics or through genetic.
Twin Cities Orthopedics just acquired their second system from us.
Did they get a discount?
We don't give discounts. Just kidding.
Volume discount. All right, so one of the things I'm interested in, we as consumers need to be far more informed about these kinds of decisions. And I think part of what I've heard in personalized medicine, part of what I've heard, if I need a knee replacement, I need to be smarter about what the physician tells me. Where do you see the consumer driving some of the changes we've talked about in some of the technologies, or perhaps even in personalized medicine?
I'll take it from our standpoint. Again, our goal is to be on Oprah, because once you're on Oprah, you're golden, and so we're working towards that. But if you think about it, it's an educated consumer, right? So your physician says you need a knee replacement. The first thing you do is you Google, I need a knee replacement, and now all of a sudden you have all of these options that you didn't have years ago, and so you start the exploratory process, you start asking your friends, and the next thing you know, you come up with what maybe we do, which is a partial knee replacement that your physician didn't even tell you about, because candidly they're too difficult, they don't have technology, they don't do it. So then what happens, you ask that physician, do you do partial knee replacements? He says, no. Am I a candidate? You could be. You walk out the door, you go to the next one, and you find the physician that not only has the capabilities, but point you in the right direction with the technology that will benefit you down the road. So it's an educated patient, which has changed the game drastically.
Comments?
I think, as I said, it's participatory. If you expect individualized medicine, you have to take an individualized interest in your medicine. And I think we need to create some public awareness that patients become their own best self-advocates as they talk to the physicians and find physicians. I'll give you just one personalized medicine example. I have a stepson with autism. He's on this regimen of psychiatric drugs that have not been working. There are genetic tests for some of these drugs. I asked his psychiatrist, would you run the genetic tests? His answer was, I can spend $100 and we'll know in 6 weeks whether the medication works or not, whereas it's going to cost $1,500 to do the genetic testing. I thought my wife was going to hit him, because it's 6 weeks that the patient has to suffer with this. We did the genetic test. We discovered that he was on a drug that does not metabolize well in his particular system. We shifted those drugs, and he's in a much better place. Now, I should say, in addition to switching drugs, we switched psychiatrists.
Yes.
And that was part of our self-advocacy.
Well, I have been reading healthcare reform policy for 30 years, and there's been this dream that the consumer is going to be smart enough and motivated enough to comparison shop for MRI, to comparison shop for doctors. I don't see that practically on the horizon. So a question for our panel here is, where are we in that process as a healthcare system and as an informed consumer?
I think the dollar is going to drive this, and I agree with you, Lee. I think the dollar is going to drive it. I think the insurance companies are taking the lead. They're grabbing the driver's wheel. They're going to define, to a large extent, how treatment is being delivered, and they're going to, again, go towards more homogenized outcomes and care, hopefully uniformly high-quality care. So it won't really matter whether you're at Twin Cities Ortho or you're at, Fairview or wherever. You can, if you're going in for care, you can be assured you're going to get excellent, high-quality care uniformly. That's, I think, where it's heading. Now, I know, patients look at Dr. Google, And, you know, okay, my mom's going in for a hip replacement, I'm sure. She's 89. She insists it has to be an anterior approach because Dr. Google recommends this. And so she goes to her doctor, who she likes, at Regent's Hospital, and he says, I wouldn't do anterior because I haven't done very many of them. You shouldn't go to a doctor who hasn't done at least 50, so they know what they're doing. And so she's got this trade-off now. Do I go for anterior approach, which may not be the right thing for her, or might? And does she go to Regents? You know, so she is trying to drive her care, because she does that. But this is where I think if we can get to a stage where we can raise a level across the board, and I think that's where the insurers are taking it, I think that's where all this gets done.
Yeah, and maybe a specific example from our standpoint is our technology does not need a pre-op CT scan. We do everything in the operation, whereas our competitor needs a CT scan, which is done 2 to 3 weeks before. It goes through segmentation. The patient gets on the table and they align the patient with the CT scan. There are several states where insurance companies now have determined they will not reimburse that CT scan as it's not necessary. When they look at our technology or they look at manual instrumentation, which is the standard of care not to have a CT scan, they have shut down reimbursing this. So if the patient wants our competitor's technology in a state such as Ohio, they will have to pay out of pocket $400 or $500 to get this procedure done for that CT scan. Perfect. I mean, that's exactly the way healthcare should go. It's not a necessary procedure.
So the dollars drive it.
Right.
Let me comment one other thing, and again, it's personal experience. One of the things that many of you maybe have experienced is that, and I'm not meaning to slam the medical profession, but oftentimes specialists don't talk to each other. And the management of care is often across multiple disciplines. My stepson sees neurologists, sees physical therapists, sees behavioral therapists, sees psychiatrists. And oftentimes the person who manages all of those interdisciplinary approaches is us. That's not what we're supposed to be doing. We feel very fortunate now that our psychiatrist is now talking to our behavior therapists. They're comparing notes, and I do think the medical profession has to have that awareness as well, that the specialists need to be talking to each other, because what one person is prescribing is going to affect the other person's discipline as well. And we need to keep that in mind. And you, again, as advocates, as patients, need to ensure that your doctors, if there are multiples, are talking to each other.
Are these physicians all in the same system? Because that's one of the justifications for consolidation among providers, is that one system is going to have a continuum of care. Has that been your experience?
Our experience has not been, in part because we haven't always been comfortable that the system, you know, that the managed health care clinic at one place has the best therapist, the best psychiatrist, the best neurologist, the best sleep doc that we have available. So we do shopping.
Yeah. And if you think about it, you look at the lingo, right? Stroke centers have now become very common, and you see the stroke centers. 10 years ago, the stroke center was either driven by the cardiac guys or the neuro guys, but in a lot of instances, you didn't have a cardiac guy in a neuro stroke center, and these are all intertwined. I mean, a stroke is a cause that both should be engaged in, and if you don't have the cardiac guys or the neuro guys, you know, forming one team to make this the right diagnosis, the patient has no chance.
Okay, so even the concept of a stroke center is interesting to me. As a consumer, am I supposed to know about a stroke center? Should I be talking with my provider about, you know, the next 25 years of my life and tell me about your stroke center? Is that smart consumer behavior?
It's a trick question.
No.
Okay.
No, I don't think so.
Yeah.
I don't think so. Look, you should be able to go to your doctor, your general practitioner, tell them what your problem is. They should be able to direct you where you need to go. And that is generally, I think, what most patients want. Someone they trust, someone who understands them, someone who they've been with for a long time. That's what they want. And I think that's what they should expect. And they should expect that the system they get sent to is going to integrate, do the right thing, and hopefully the payers or whoever is paying the bills insists that that's how it's done. Hopefully. They're not all that wise, you know, but
That's the hope. And it should stretch across, right? So it doesn't need to all occur in the big city because we have digital technology. So out in the middle of nowhere can have a radiologist that's getting an overread or a support read from the guy in town who's the specialist in this bone break or something that says, hey, we're all in this together. We've got a relationship, even though we're out in the middle of nowhere, with Twin Cities Orthopedics, and that's what will allow us to take the future, not just to downtown Minneapolis, but to wherever we are.
Well, I think one of the other components of the future of medicine that has to be addressed is the medical record systems. Many hospitals have Epic, and the rule of thumb is if you've seen one Epic, you've seen one Epic. And the Epics don't talk to each other. Even hospitals within the same system oftentimes have medical records that they can't transfer from one hospital to the other. This is a major problem. If you're going to have effective integrated healthcare, you're going to have a system that allows hospital medical records to talk to each other. And it's a problem, and people are facing the problem. It's recognized as a problem. It isn't solved yet, and with all of the information we're talking about, including genetics, the amount of data that's accumulating is enormous. There has to be systems that integrate that data and that information.
One of the things I've noticed about medical records is that when I have my annual physical, my physician no longer makes eye contact with me. He's making eye contact with Adele. I mean, it just clack, 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 it's just, is that a good thing?
Takes the intimacy out of the physical.
Maybe, I don't know. It's maybe a good thing. Maybe.
Yeah, I think, I'm doing a lot of writing right now about the strengths and weaknesses of data mining. I think we're in that phase right now where we're seeing a lot of strengths and we need it, and we're going to get good at it. Ultimately, we're going to find that we're basically making medical decisions on what I call correlational data, correlational connections, and we're going to have a pendulum swinging the other way towards more causational kind of analysis. But for now, I think we need this. I call it data mining the fingerprints of God, and that's what it is. So it'll take us a long ways, and then we're going to, I think, swing back the other way eventually to get into it. So what are the causes of all this stuff? Which is probably coming back to what Brian does.
Often at these kind of panels, somebody then asks about big data, which I find kind of aggravating. These are people who don't use the small data they're handed every day. But that's basically what you're talking about. You're talking about massive databases and deriving useful information from them. Is that what you're talking about?
Yeah, I mean, consider your genome has bits of information, the bases that make up your DNA sequence. You've got, within every cell, you've got 3 billion of those base pairs that are occurring in every cell. And so the record is going to say, well, if it's individualized and it's you, that's 3 billion pieces of information times every patient, times all the correlation. And by the way, don't get me wrong, I'm not suggesting genetics is the answer. I'm suggesting that genetics is simply an additional part of the toolbox. Right. And so now you've got to integrate the genetic big data with all the imaging big data, all of the blood chemistry big data, and all of the data that's there. It's getting bigger.
Okay, one final question from my perspective, and it's really a Twin Cities-based question. Twin Cities has been a hotbed of device innovation for, going back to shortly after the Second World War, largely based on the University of Minnesota early on. I'm wondering if, based on what I'm hearing, that the period of great change in devices might be coming to a close, and that innovation is moving to different parts of the healthcare delivery system. Is that a fair conclusion? And you're all Twin Cities folks, and what does that mean for our region?
Look, I spent 32 years basically. I'm a product of a bunch of Medtronic alumni and St. Jude alumni, and hey, listen, I came up through that medical device background. It's my frame of reference. And I do think we're nearing the end of that period, and we're getting to a period where, again, we're focusing more on these long, unsolved, critically necessary issues of consistency, reliability of outcomes. I think that's really where we're going. But what's interesting is, so here I'm conveying this message, both here in my writing, in all other talks I give around the world. Here you have Eric,
who came out of this same kind of environment, and he's driving it with his company and his innovations. I mean, you have here 3 Twin City guys who are, in our own way, taking the legacy of this region, learning from it, being open to making a change, and then driving those changes ourselves in our own respective areas. And I think we are all products of the Twin Cities, we on this panel. And maybe, I don't know what it is about the Twin Cities, but we're open enough to take that history and change. You know, don't necessarily let that lock us into a pathway, but be open to another direction. And actually, I think this is, you know, Twin Cities are still as vibrant as ever tonight.
That's what I was going to say. I would tell you, and it's my very humble opinion, there are more brilliant ideas coming out of this system, this city in the med tech, med device space than anywhere. And I play in New York, I play in California, I play in Boston. When you sit in the room and you look at who's coming out of the Medtronics, the St. Jude's, all of these companies with new ideas, novel ideas that end up making impact on patient lives, there's no better place to be. Part of the issue is the U.S. regulations that we face. And so now you see a lot of the things that should be done in the U.S. moving overseas, moving to India, moving to Europe to get all the testing done, all of the things that we need to do to bring these products to market quickly to treat our patients are now going overseas, and it's all driven by the government, which is absolutely the wrong direction.
Let me also comment that there's been a shift, I think, in academics. So, 20 years ago, when you were an academic researcher, you were discouraged from developing entrepreneurial development because it conflicted with your academic mission to go out and try to make money outside the university. In the last 10 or 15 years, the university has had a complete shift in its approach to this. And actually, through its Office of Tech Transfer and Commercialization, is actually encouraging faculty, going out to faculty and saying, please go out and have an impact in the community and get outside the ivory towers and get out there and have an impact. And so I think the university's academic mission in the last 10 or 15 years has had a significant shift in being insular and protective and, in fact, stifling that innovation to going out and saying, what can we now do in the community? And I think that's an important shift in academics throughout the country.